Hello, everyone. Oh, my goodness. I'm Amy Rick, the CEO of the Parkinson's Action Network, and I want to thank you all for coming this evening. As everyone in this room already likely knows, telehealth or telemedicine, and you will hear them used interchangeably tonight, is the use of medical information exchanged from one site to another via electronic communications to practice medicine. Telemedicine includes a growing variety of applications and services using two-way video, email, smartphones, wireless tools, and other forms of telecommunications technology. Telehealth is widely used in rural populations, military populations in combat, for emergency stroke care, and by the VA. In fact, the Veterans Affairs Administration is encouraging the use of telemedicine by right now waiving a patient's copay if they seek medical care via telemedicine. Telemedicine is also used in some private managed care systems. In 2013, Kaiser Permanente had 10.5 million patients utilize their telemedicine system to connect with a care provider. That's really a remarkable number, actually. So why is this an issue for PAN? Why is the Parkinson's Action Network doing this tonight and pushing for greater adoption of the use of telemedicine? You may not realize that according to a recent study, at a minimum, 42% of people with Parkinson's disease get their care from a primary care physician. But the study also shows you have a much higher quality of life if you get your care from a specialist, either a neurologist or a movement disorder specialist. That's really important to our community, and some estimates go as even high as 60 to 70% of people with Parkinson's do not get their care from a specialist. And there are many, many reasons for that, but some of them are simply access to a specialist. Telemedicine is not available to many people in the Parkinson's disease community for a number of reasons. Upwards 70% of people with Parkinson's disease are on Medicare, but Medicare will only reimburse for a telemedicine visit that's in a designated rural area and not at all for therapy services using telemedicine. Also, there are significant licensure barriers to allowing a doctor to cross state lines and treat a patient in another state if he or she has not gone through the burdensome and expensive licensure process in that state. Licensure barriers are often discussed as a way to protect patient safety, but quite frankly, we question that. PAN's goal in our advocacy is to make telemedicine available as an option to anyone who chooses to seek medical care, whether it is by a specialist, therapist, or other healthcare professional. There is a movement in the adoption towards telemedicine. Many states now have legislation that mandate payment for use of telehealth for Medicaid, and some also include private insurance in that. But we have a long way to go, particularly in the area of the federal programs. There was a hearing in the House just last week, which I find encouraging. There was a great Energy and Commerce Committee, great enthusiasm for learning more about the opportunities in telemedicine. And right now, there are two pieces of legislation on Capitol Hill, which PAN supports, that would resolve the licensure issue for the VA, for the Veterans Affairs programs, and for Medicare. It would be a wonderful step forward, not a complete step, but a step, and an outstanding message if these pieces of legislation passed. But licensure, as I said, is only part of the problem. Currently, there is no comprehensive legislation on the Hill at all that would mandate that Medicare fully adopt paying for telemedicine. We need that in order for the Parkinson's disease community and to have broader access through telemedicine to the care they need. The bottom line is that telemedicine provides great opportunities for greater access to care for more people at less cost and burden to the patient and the caregiver, and sometimes to the health system as a whole. And that is what tonight's educational event is all about. Before we start the program, I'd like to start by thanking two people on the PAN staff who worked hard to pull this evening together, Catherine Pugh and Michelle Dooley. And I would also like to thank Senator Daschle, who is here tonight, and for his outstanding leadership on this important issue. It's to have someone of your stature and strength of voice to come into this issue, we really do believe will make a difference. So we thank you, Senator Daschle. And I especially want to thank the Feinstein Institute for Medical Research. The Feinstein Institute hosted a Marinoff Symposium series on telemedicine and Parkinson's disease about 1 year ago. Ray and I were on the show and tell for that too. And it was through working with Feinstein on that symposium that PAN became committed to the issue of telemedicine and the promise that it holds for people with Parkinson's disease. The Feinstein Institute has been a tremendous partner on this issue and supporter on this issue on behalf of the whole Parkinson's disease community, and I give them our sincere thanks. Also, the Feinstein is our sponsor for this evening's event, so all of you should be thanking them as well. And now I'd like to introduce Dr. Czura. In addition to being the executive producer of the Marinoff Symposium series at the Feinstein Institute, Chris is the vice president of the Feinstein Institute for Medical Research and executive editor of the international peer-reviewed journal Molecular Medicine, and a good friend to PAN and the Parkinson's community. Chris?
Thank you very much, Amy, for that kind introduction. As Amy mentioned, I'm Vice President at the Feinstein Institute for Medical Research in New York. The Feinstein is actually the research enterprise of North Shore LIJ Health System, one of the largest healthcare systems in the country. And we are responsible for, primarily our goal is to change the way medicine's practiced, to help develop and help invent and help development the new technologies that we need to help treat our patients. The Feinstein is recognized as a leader in Parkinson's disease research and is leading the world in establishing network-based biomarkers in Parkinson's disease using advanced brain imaging technologies. This breakthrough will go a long way toward offering diagnostic capabilities to patients in remote regions who do not have access to specialized care. 3 years ago, we committed ourselves to promote and support the use of telehealth in Parkinson's disease because we recognized the immediate value and impact it would have for patients suffering with Parkinson's. As part of our commitment to this topic, we hosted the Marinoff Symposium last April. And in that meeting, we convened the thought leaders in clinical care, research, philanthropy, patient advocacy, and importantly, the patient population as well. And the goal of the symposium was to cause these groups to look at the challenges and opportunities that telehealth, that implementing telehealth would have for this patient population. The result of the symposium was a unanimously supported message of hope and a call to action. That message of hope was easy to identify: increase access to expert care to improve patient outcomes. The adopted call to action was threefold: raise awareness about the legislative and reimbursement barriers standing in the way of proliferation of telehealth services, update the cross-state licensure regulations in order to reflect the borderless nature of the connected world, and enact a reimbursement policy that encourages, or at the very least supports, the use of telehealth services. The Parkinson's Action Network has been a champion of these enormous goals. PAN's activities have included the close and careful stewardship of the quality of language used on the Hill, leading and connecting several patient groups in support of telehealth, and providing testimony to the Federation of State Medical Boards and on Capitol Hill. Dr. Ray Dorsey, who has been at the forefront of clinical application and research in support of telehealth care for neurologic disorders. In addition to providing care for Parkinson's patients who might otherwise have access to a neurologist, Dr. Dorsey is a champion among his peers and continually challenges them to expand their use of telehealth to treat more patients. We welcome the Alliance for Connected Care and laud them for their specific goals to increase the adoption and implementation of telehealth. Having the leadership of two former Senate Majority Leaders to encourage Congress and the administration to use these tools to improve quality and efficiency demonstrates the importance of this issue. It is our pleasure to host you this evening as we continue our work to improve the lives of those suffering with Parkinson's and other diseases. It's also a privilege to welcome DLA Piper's Senior Policy Advisor, Senator Tom Daschle. Senator Daschle brings unrivaled leadership and passion on this topic of healthcare, and through the formation of the Alliance for Connected Care has created more than just a trade association, but a bipartisan campaign to make telehealth a nationally available tool. Senator.
Thank you very much, Dr. Czura, for your kind words and your introduction and for your leadership with the Feinstein Institute. We are very grateful to you and the Institute, especially for bringing us together this afternoon. And what a pleasure it is to meet Dr. Dorsey. I've heard about him and of him for a long period of time, and I'm thrilled and honored to share the dais with him as well. But I especially want to thank Amy and Pan for their leadership. Their advocacy on behalf of the Parkinson's community is unrivaled, inspirational, and deeply, deeply effective. We are experiencing, in many respects, the greatest transformation in health that any of us have witnessed in our lifetimes. The collective goal to build a high-performance, high-value healthcare marketplace with better access and better quality and lower costs can be achieved, but only if the collage of subsystems, public and private, this collage that is forced in many respects to work together, can be more collaborative and can do a better job of bringing about greater efficiency and better access and certainly higher quality. And only if our policy and regulatory framework can keep abreast of the dynamic change in technology will this happen. Only if we reduce the level of political polarization to enable this new health infrastructure to be constructed effectively. Only if we can make our system work better can we achieve those goals. But as I stand before you this afternoon, I can honestly say I'm cautiously optimistic that this can be achieved. One of the reasons is because there is now near recognition, a universal recognition, that health IT can bring enormous added value to those very important healthcare goals. There may be no better example of this than telehealth. Increasingly, it is recognized as the critical transformational factor as we look at our ability to coordinate care and to improve quality outcomes across the board, to connect patients and providers with greater ease and less cost, thereby reducing costly hospital emergency room and expense, but especially connecting people who right now have very little access. People in my state of South Dakota, in many rural areas, in those urban centers where they simply have no opportunity to talk and meet and be treated by providers today. Telehealth can be particularly impactful for patients with chronic disease especially, and I would say that's particularly true of Parkinson's. But to maximize the enormous potential, we have to ensure that the policy and regulatory framework at both the state and the federal level is integrated effectively with this technology. It is why Senators Lott and I and Senator Breaux joined together to form the alliance to what we prefer to call connected care. The alliance is obviously bipartisan, but it includes leading companies from across the healthcare spectrum, insurers, retailers, pharmacies, technology, telecommunications companies, and healthcare entrepreneurs. Our objective can be very clearly and simply stated: to create a regulatory and statutory environment in which every provider can deliver safe, high-quality, accessible care with telehealth technology and be compensated for it. We are making great progress and continue to add new members almost by the week. Krista Drobac, who will momentarily give you a report on a release of the literature review that we've just conducted, I think is especially due great recognition and thanks for her extraordinary leadership in making this happen. But it provides a compelling amount of evidence that telehealth truly can move us closer to the goal that I think we all aspire to: a high-performance, high-value marketplace with access for everyone. So this is a transformational time. About that, there is no doubt. Filled with great expectations for our ability to make real progress. Those of you here today are at the epicenter of this change, and for that I'm grateful. And I know I speak for everyone in thanking Amy and Pan for their leadership in bringing us together. Thank you all very much.
So now we're moving to the second portion of the program, and it is my pleasure to introduce Krista Drobac and Dr. Ray Dorsey as our next speakers. Krista is a senior policy advisor in DLA Piper's healthcare policy and regulatory practice and serves as the executive director of the Alliance for Connected Care. We're so grateful to Senator Daschle and Krista for creating the Alliance to bring the many disease groups and organizations interested in telehealth together to tackle the many legal and regulatory hurdles that we have to adopting telehealth more universally. As we were discussing before the program started, I am so grateful for this coalition because PAN has been active in this, or this alliance, sorry, active in this area for a while, but no single disease community, no single disease group has the resources or the or in some ways even the right to push one issue. We really need to come together, and the alliance is helping us do that. Krista has an extensive background in health policy at all levels. I won't give her whole bio, but prior to being at DLA Piper, she was the director of the health division of the National Governors Association Center for Best Practices, where telehealth was one of the issues under her jurisdiction. And then we'll hear from Dr. Ray Dorsey, who we've referred to already. Ray is a professor of neurology and co-director of the Center for Human Experimental Therapeutics at the University of Rochester Medical Center. Ray has been a true pioneer in research into telemedicine and Parkinson's disease. I first heard of it actually through Ray, a congressional briefing we did years and years ago. And I was like, what is this guy talking about? In 2009, he published a study that showed using telemedicine to allow movement disorder specialists to reach people with Parkinson's who were in a nursing home care setting and otherwise did not have access to such high-quality care resulted in actual improvement in both cognitive and motor symptoms. Ray is now a co-principal investigator in a larger patient-centered outcomes research institute funded study with the National Parkinson Foundation that is comparing the effectiveness of specialty care delivered by telemedicine to that of a patient's usual care enhanced with educational materials. So with that, I'm going to turn it over to Krista.
Thank you. Is this on? Can you hear me? Thank you so much for the invitation to be here. I'm so privileged to be on the panel with you. And I'll just fill out a couple of the details of things that the Alliance is working on right now. We looked across the regulatory and legal landscape, and we found some low-hanging fruit things that could be done by the administration today to further provide access to telehealth. So I'll tell you about that. And then we also are working on a legislative proposal. We also noted that there are proposals that address licensure or reimbursement or a definition of telehealth, but no single bill that brings them all together. So we're working to have leadership in Congress introduce a comprehensive bill that is really consensus-based and that can get the support of the private sector, the patient groups, and others so that we have a chance to actually pass something. So on the low-hanging fruit side, we have asked the administration and actually have gone in with ACOs to ask the administration for the secretary to use her waiver authority to waive reimbursement restrictions for ACOs.
You might want to explain what ACOs
Oh,
are.
sorry. Accountable care organizations. It's the great white hope in the ACA for saving money. And ACOs are an experiment that the administration is very invested in, and in fact many health systems are also very invested in, and in fact some ACOs have found that telemedicine, telehealth can, and remote patient monitoring as well, can reduce costs and improve patient care, patient satisfaction, care coordination. The problem is that some ACOs won't invest in it because they can't afford it, and if it was reimbursed, it would actually be more widely used among accountable care organizations. The secretary has authority was given to her in the ACA to waive basically restrictions that could make the ACO program work better. And we've made the argument that telehealth makes ACOs work better. In fact, we weren't the ones making the argument. We let the ACOs do that. We just helped facilitate it. And so we are hoping that the administration will consider using that authority. That would give about 5 million patients access to reimbursed telemedicine services. There are about 5 million patients in ACOs today. Another thing is there's really no definition of telemedicine, a consistent, standardized definition. And in fact, we use connected care, and under that, there's no telemedicine, telehealth, remote patient monitoring definition. So in fact, there's 7 different definitions at the federal level alone, and then multiple at the state level. So we are asking the administration to consider a stakeholder process to bringing patient groups together with technology providers and broadband infrastructure providers and others, everyone who cares about telemedicine, to define it and to issue some non-binding guidance that's sort of a consensus-based definition of telehealth. So those are a couple things that can be done without any legislative authority today. Then we are working on a legislative proposal. And the basis of the legislative proposal on the reimbursement front is really evidence that this can reduce costs and improve care. And at the very least, if it doesn't reduce cost, at least not blow the budget. Because I think, you know, we're worried that CBO will just think if you turn on a code that everyone will use it and then your utilization will go way up. And what we're trying to say is, but there's another side of the ledger. And if you increase the use of telehealth and remote patient monitoring, you can actually decrease inpatient costs. And so to that end, we have commissioned a study which will be released in the House on May 20th and in the Senate on May 21st. And we commissioned 2 professors, one from University of Michigan, another from University of Kentucky, to look at chronic disease. We had to narrow it down because there's such a voluminous amount of literature. So they ended up looking at CHF, COPD, and stroke. And they narrowed down the literature by looking at only research-based publications and only research designs that had a sample size of more than 150. So we really wanted randomized control studies. And the evidence was great. I called the professor at one point and said, do I have to start worrying now? Or what are you finding? And he basically said, we're even in a better position than we thought. We're finding even better evidence than we thought. So I won't give away too much, but essentially in CHF, they found no difference in quality, and they found that telehealth was very useful in predicting hospitalizations and improving medication adherence and a reduction in admissions. In fact, the VA found a 26% reduction in admissions in CHF using telehealth, and they also found lower costs. So we were excited about that, and the other 2 were very similar, and I don't want to go over my 7 minutes, so I'll talk to you after if you want to know more, but you can also come to our event, which is May 20th in the House and May 21st in the Senate.
Thank you, Krista. Ray.
So first of all, thank you, Amy, very much for the introduction, for organizing this. Thank you very much to the Feinstein Institute for supporting this effort. Thank you very much to my many friends and colleagues here who have been supporting our efforts to provide care to anyone, anywhere with Parkinson's disease. So first I'll start with a question. How many people here have ever received a house call of any kind from a doctor? Yeah. So, and how many people found that to be a beneficial experience? They enjoyed it.
But it was so long ago. I know.
So before World War II, 40% of all visits were house calls. As late as the 1950s, 10% of all visits were house calls. Now, the challenge is that it fell out of favor. By 1993, it was only less than 1% of all visits were house calls. And the challenge we have right now is we have a growing number of older Americans who have chronic conditions who want to receive care in their home. And we right now are having the first generation of Americans, I won't ask who in the room is in this generation, who have paid into Medicare for a half a century. So since its inception, there are people now with Parkinson's disease and other chronic conditions who've been paying into Medicare for the last 50 years. And unfortunately, Medicare right now is probably the largest barrier to our being able to provide care to individuals with chronic conditions in their home. So we're trying to bring back the next generation of the house call, and we're doing that by using technology, the same technology that people use to communicate with their grandchildren or their children. You know, we're using essentially HIPAA-compliant Skype to connect patients wherever they are to providers increasingly nationally. As Amy pointed out, we started this out over 6 years ago when a nursing home in upstate New York, in New Hartford, New York, population 20,000, outside of Utica, outside of Syracuse, said that we have about 50 residents with Parkinson's disease and no neurologist to care for them. Would you be willing to see them remotely? And my colleague, Dr. Kevin Biglin, and I said, sure, why not? And that began our journey, which has brought us to this point. We conducted a small pilot randomized controlled trial there, showing that it was feasible to provide care to Medicare beneficiaries who resided in nursing homes. We showed that it improved their quality of life and actually improved their Parkinson's disease symptoms relative to the care that they were receiving in the community. About 3 years later, we extended our reach from nursing homes to patients' homes directly. We did a small randomized controlled trial in Maryland and New York, and we demonstrated that providing care into patients' homes was feasible. Actually, more of the virtual visits were completed than the in-person visits. One person even got in a car accident coming to see us for their in-person visit. So you can just think that we know that individuals with Parkinson's have impaired driving abilities, so we know that there are better and safer ways of providing care. We demonstrated in that study that the quality of the care as measured by quality of life and Parkinson's symptoms was comparable between the two groups, a small study. We showed that each virtual visit was saving their patients and their caregivers 3 hours of time and 100 miles of travel, each visit. Patients, we asked them to time themselves from the time they left their home to the time they returned just to see me for 30 minutes. They're spending 255 minutes to come see me for a 30-minute follow-up appointment. If you extrapolate that across multiple chronic conditions, if you extrapolate that across the lifetime of an individual with Parkinson's disease, 14 years, it's tremendous potential to save time and travel and many other secondary benefits from providing care this way. With the support of the Verizon Foundation, we offered anyone in 5 states where I'm licensed the opportunity for a one-time consultation in their home, regardless of ability to pay, for free. We just saw anyone, anywhere. We saw people in Palo Alto, California, and in Manhattan, New York, not surprisingly. We also saw people in Fresno, California, Pensacola, Florida, Lewis, Delaware, Binghamton, New York. And out of those visits, 3 themes came out. One was care. One daughter of a patient we saw in Fresno said, "We had a good family crying moment after the visit from just the pure joy of having my father be able to see a Parkinson's disease specialist. Never been able to do that before." The second was convenience. Not surprisingly, we enjoyed being able to see the doctor without having to travel 3 hours of time, pay for tolls, parking, and my wife having to take off a day from work. And then the surprising one was comfort. Patients felt more comfortable, protected by, in their words, the veil of technology. They felt the visits were more comfortable. They were in their own home, their own environment. I learned a lot more about their patients and their lives. I saw their caregivers. I saw their spouses. I saw their pets. I saw their kitchens. I saw what they were having for lunch. I saw people in various layers of clothing, sometimes a little bit too little. But you got an entirely different view into their lives. So why can't anyone, anywhere receive the care that they need? And there are 2 principal barriers. The first is reimbursement. Medicare reimburses for telemedicine only in very limited circumstances. You have to reside in a health professional shortage area, and that definition can change over time, as we found out. And you have to receive your care in a medical facility, like a doctor's office or a hospital. So if a patient comes and sees me in a hospital-based clinic, I get about $160 from Medicare for a follow-up visit. If I see them in a suburban community-based clinic, I get about $80. If I see them in their home virtually, I get $0. So right now, Medicare incents institution-centered care and disincents patient-centered care. The second major barrier is licensure. You have to be licensed in the state where the patient is physically located at the time services are rendered. So I used to practice in Baltimore, and I see patients from West Virginia, I see patients from Pennsylvania, from Virginia, and I couldn't see them remotely because I'm not allowed to practice in states that I'm not licensed. So someone could drive down from Harrisburg to Baltimore, or from West Virginia to Maryland, or just from here, from Washington, D.C., and I couldn't offer them the opportunity to be seen remotely. Those are the 2 principal barriers, and we think these are addressable, and we need your help. We have a tremendous opportunity here. If you think about the entire history of medicine, the care people received was dictated by two factors: who they were they the right race, were they the right sex, were they the right religion, were they the right age, and the second is where they lived. Did they live in an environment where they could readily access the care? And increasingly, we have the ability to provide care to anyone, anywhere. And this is something unprecedented in the history of medicine, that we can reach anyone, anywhere with using simple, inexpensive technology. In order to do so, we need your help. Thank you very much.
So, Ray, thank you for everything you're doing, and there are so many questions. My first question will follow up on your last remark, care for anyone, anywhere. But the patient still has to have the right technology. Will there be inequities in telemedicine, access to care through telemedicine, that actually create the divisions you were just talking about?
Absolutely. Those divisions will be less than the divisions there are currently. If you're African American, you only have 25% the chance of being treated with medications for your Parkinson's disease as if you're Caucasian. If you reside in Delaware, there's not a single Parkinson's disease specialist to care for you in the entire state. If you're in South Dakota, there's one. If you're in Idaho, there's one. So there's no question there will be a digital divide. That divide is getting smaller and smaller. The fastest growing segment of users of social media are individuals over age 50. So yes, there will be limitations. Those limitations are decreasing and will only get smaller over time and are much, much smaller than the current disparities that we currently face.
Krista, for you, one of the challenges we've had with trying to move Medicare to reimburse for telemedicine visits is that the savings realized in the 3 C's that Ray listed are all savings or benefits to the patient. And that matters a lot to me, it matters a lot to everyone in this room, but it's not a cost savings to Medicare. So I'm pretty excited about what you found in the literature review that maybe we can present savings. Will we have to be able to show cost savings to the system before there's an appetite on Capitol Hill for more comprehensive legislation?
I think the appetite among lawmakers is there. It's the Congressional Budget Office and MedPAC that are more skeptical, and really they are so influential. And so our efforts are really targeted obviously towards the Hill, but also towards them to help them see that that these new technologies are actually improving or increasing cost savings. And so there are lots and lots of studies. Ours is just a review of random, controlled studies, but there are lots of ACOs that are showing double-digit decreases in inpatient utilization because of telemedicine and remote patient monitoring. So I think there is appetite on Capitol Hill. It's just, can they get a score that is going to enable them to pass the bill? And this is obviously very inside baseball, DC stuff, but if you have CBO saying that it's going to cost money, then you have to find the money elsewhere. So that means you're pitting telehealth advocates against somebody else who's going to lose their money. So as much as we can show that telehealth is either a saver or is just going to be a wash, the better off we're going to be legislatively, because we might be able to get something done.
So along those lines, and this is kind of a strategy question, in this area, I know, as I mentioned, a number of states have passed legislation mandating the reimbursement for telehealth in the areas they can control, Medicaid and private payer. Is this an area, even though normally for a federal program we'd go for federal legislation, are we better off hitting this issue in the states and one at a time knocking off so eventually Medicare has more pressure to do something?
Well, 20 states already require commercial coverage of telehealth, and hasn't moved the needle at all in Medicare. I don't think, coming from the National Governors Association, actually I worked on the Hill too, so I've got both the federal and the state perspective, and
did either one work?
Neither one of them look to each other. They each think that the other is not right, and so I think you're better off working both angles. Mm-hmm. The Alliance so far has not gotten involved in the state-by-state issues. I think what we feel is that if we could get Medicare reimbursement, all the rest of the markets will follow. And so we're putting our eggs in that basket, but you should work on both, really.
Yeah, I mean, we often, so goes Medicare, so goes the rest of the country. Right. There's no doubt about it. Ray, I know we've talked about the fact that in the licensure issue, which is up at individual state medical board decision usually, one of the justifications used for insisting that you be licensed in 5 states, ultimately 50 if we don't get anywhere here, is patient safety. But I can get in my car and drive to another state and see a doctor of my choosing. And no one has ever told me that I'm putting myself at risk and I'm not safe if I do that. So what is the justification for not letting me make the same decision just using technology?
That's a good question for them.
Okay. Another one for you. You're in the medical school, so you can't back out of this one. What is going on in medical schools and residency programs to train the next generation of doctors on how to practice medicine using telemedicine? Because it has to be different. I know we talk about it being equivalent and access, but it is a different way to see a patient.
Very little. And telemedicine is used all the time, every day. So in Canada, 300,000 Canadians in Ontario receive care via telemedicine every year. In Kaiser Permanente, Northern California, their CEO says with the addition of video visits, they will have more virtual visits than in-person visits by 2016. They have more virtual visits than in-person visits. The largest provider of acute stroke care in this country is an organization called Specialists on Call that provides care virtually. They prescribe TPA, which is the only approved drug for acute stroke, 3,000 times a year. By far the largest provider of acute stroke care. Medical centers are trailing oftentimes in terms of the education. There are colleagues of mine who all they want to do is practice via telemedicine. We have, many people who are helping us in our research studies are often mothers or parents with children who can't work in a typical 8 to 5 clinic setting, and they see patients at their convenience, when their children are at school or in the evening or whatever it is. I mean, there's just entirely new ways of delivering care that we haven't even scratched the surface of. So we need to be not restricted to the existing standards of care, because they have put us in the position where we are right now, where people aren't able to access care, where we spend 40% more than any other country per capita. But think about enabling policies that can let us do the things of the future.
Interesting. Also interested in, and this is my last question, then we'll open it up for questions. You referred to the benefits you have of, mostly benefits of seeing someone in their home when you're actually having that visit. But you've also, if I'm correct, you've also had telemedicine visits in rural areas under Medicare where the patient is in the originating site. So you've experienced in-person where they're in a clinic, but you're still using Skype-like technology, and then when they're in their home. What is the difference? Do you feel there's different benefits and cons between the clinic originating site and someone's home?
I think it's a function of what meets the needs and interests of patients. Some patients actually may be more comfortable being in a clinic setting where there's a nurse or a nurse practitioner or a health aide who's got the technology already set up. They're in a clinical setting. They can help them, walk and do portions of the examination. I increasingly think that people will not only want to be able to do in their home, you want to be able to press a button on your smartphone or whatever the device will be of the future and be able to see your clinician. And I think that's the way that people want to do this. I was speaking earlier, it's just like ATM machines. You used to have to go to the bank to get your money. Then you went to an ATM machine that was in the lobby of the bank. And then the ATM machine went outside the bank. And then it went to the library. And then it went to the 7-Eleven. And now it's everywhere. And I think that's the same thing will happen with care, and that people will get increasingly comfortable and will increasingly want and hopefully demand to be able to receive the care that they need wherever they are.
John.
Perfect word to pick up on.
You can wait for the mic because this is being taped. There we go.
The word patients will demand. You started the panel with costs and Medicare rules. And I sit here amazed by that conversation, not because of you three or you two, but because where's the conversation about patient outcomes? And how much will that figure into the mix when you go to the Hill? Because I like to listen to both of you, I'm sure, but I really like to listen to Ray, because it's kind of a no-brainer. This just doesn't seem that hard, doesn't seem that complicated. We've had technology and global companies for decades, 50 years in my own personal experience. This is a no-brainer. Why, or how are we going to help you guys get this done?
Can I take a shot at that?
Please.
So one of the things that I've always said since we started this is if the FDA tried to take away someone's wearable or their app on their smartphone, their healthcare app, consumers would go crazy because it's ubiquitous now. I mean, everybody's wearing the wearables, and I bet you everybody in this room has at least one app on their phone that has something to do with healthcare. And the problem with telehealth and telemedicine is that the technology isn't allowed to proliferate, and it isn't allowed to get into a patient's home and become part of your life because of the regulatory structure. No one envisioned wearables or apps, and so no one made a law against them or made it difficult for them to grow. The problem with telemedicine is that the way that the law is written, and was written in 2000, it has prevented it from becoming a part of our lives. And consumers don't generally rise up over something that they've never had. It's if you took it away. So we need to give them the opportunity to know that this is even possible before I think you're going to see lawmakers jumping out of the way of regulation, more regulation of telemedicine.
Just a follow-up to that, you were talking about accountable care organizations, which for the 5 million patients who participate, that's a payment structure difference where it's not fee-for-service, where the doctors necessarily get paid for every visit, but more of an outcomes-based, how well in the larger picture is the patient population doing. Because the savings there is realized by the group more, if I'm making sense, do you think that movement away from fee-for-service and more toward bundled outcomes payments will be helpful for telemedicine then?
Yes, definitely. The more we get away from fee-for-service, the better off telehealth will be. Because if you just get a capitation, I mean, this is why Kaiser is so successful in this area, because Kaiser's capitated. So they're looking for every way possible that they can keep patients from, keep patients healthy in their home and not coming in to a facility. And when Kaiser implemented email, they saw, it was fascinating actually what happened. When patients were able to email their physicians, the primary care docs actually had more time to spend with patients that had more complex conditions. So they saw their specialist referrals go way down, which was, no one ever expected that. I mean, I think if you have more telemedicine, and Kaiser's is leading the way, and the ACOs are leading the way in this, you're going to see improved patient satisfaction. And if you have a bundled payment, that becomes one of your metrics. It also is another metric to have cost savings. And so the more we have bundled payments, the better off we are in terms of telemedicine. But John, I want to tell you that we need patients to come to the Hill. We're trying to figure this out from, an inside baseball, Washington, how do we talk to MedPAC and CBO and get the numbers not to look, but what's going to really sell this is stories. And so we need you to help lobby these changes. And I hate to use the word lobby, but advocate for the changes, because that's what's going to make it happen.
This is a pretty inside baseball group. That's okay. Mike. Can you wait till you have the mic, because we're taping? Thank
As
you.
consolidation of healthcare systems grows, more and more integrated delivery systems cross state lines. What have you done to bring them to the table as your partners? They're big stakeholders in this. They've got to be able to deliver services across jurisdictions. So
from the Alliance perspective, we have some health systems that are on our advisory board, and we have, there's lots of interest. They're all interested in the licensure issue. I think it's one of our big three issues that we're focused on. And the challenge with licensure, and I think we'd all be happy if we didn't have to have 26, we have one member that has 26 licenses. And it's very difficult and very cumbersome. We want to make sure that the boards that govern this, it depends. Sometimes they're representing doctors, and sometimes they're a little bit out of touch with some of the newer physicians, the younger physicians, and we we want to make sure, though, that we bring the physicians with us so that they aren't going to say that we're somehow violating patient safety, which is, of course, not going to happen. But it's complicated. So we're trying to figure out the licensure issue. I think, Nunes and Pallone have an interesting bill, a bill that has a lot of support. There's different ways of coming at this, and the FSMB has worked on it. They did not come down on the side of reciprocity, which I think many people were.
What the FSMB is?
Oh, the Federation of State Medical Boards. Sorry. I think a lot of people were hopeful that there might be some reciprocity between states. So it's still a work in progress. There's a lot of different approaches to it.
Some academic medical centers may view this as unwanted competition. The people who stand the most to gain are the 50 million Medicare beneficiaries. And if you don't even care about Parkinson's disease, there's 5 million people who have Alzheimer's disease, and this country is going to double to 10 million. There won't be an individual in this room who won't be affected directly or indirectly. And to say that the state of care is that an 80-year-old person with Alzheimer's disease to get care should go to a major urban center, to go to the 5th floor of a parking lot to get disoriented to receive their care, and to have that process repeated every 6 months for the balance of their life is ludicrous. We need to think and need to get the AARP and 50 million Medicare beneficiaries saying this is not the way we want to receive care. This is, as children of Medicare beneficiaries, it's not the way we want our parents to receive care. We want to be able to connect to the specialists that we need, regardless of where we live.
Question back there? Oh, Walter.
Hi, Ray. I was just going to it's a little different twist. Having done telestroke for a long time, there's a huge advantage of seeing the patient with a medical professional next door. So you talked about seeing the patient in their home, which is, important for a variety of reasons. But I'd always thought that the future, the primary care physician would Skype into the specialist, and you would be able to see 50 patients a day with a primary care physician giving you the history, going through an exam on Skype, as opposed to what happens now is they order an appointment to see the consultant, which takes 3 months, and then you go through the same history all over again. Incredibly inefficient system. So what's been your experience, say, at Rochester in trying to convince your hospital to kind of hook the docs in with a specialist and is that what Kaiser's doing? Because that, I think, is tremendous advantage.
So for Parkinson's disease, for any one primary care physician, it's only going to have a handful of individuals with Parkinson's disease, so it's not worth their time and effort to connect to a specialist to do so. There are models that do this, something called Project Echo, where primary care providers in the community get hooked up to specialists to help them manage patients with hepatitis C. They usually don't do synchronous visits where they are doing the patient and the doctor in the room at the same time, because it's very difficult to coordinate that. If you think about the way we're communicating now, it's increasingly asynchronous. We text more than we phone call. So I think that's the way that it'll actually go more towards that. Like some of the biggest applications of telemedicine are radiology. So, you take the film and the film is sent to some person at some different location and sent back to you. Dermatology, you can take a picture of your rash, put a little sentence, sent away, come back to you. Even my colleagues are doing this for pediatrics. Child with an ear infection, you take a picture of their eardrum with an assistant, a little history, and that information is taken back. So I think just the challenges of coordinating it with one primary care physician, one specialist, and one patient, unless you're seeing lots of patients with that exact same condition, it'll be difficult to do.
There are companies like Specialists on Call that do have physicians who are basically just for their entire shift sitting and available. So Specialists on Call, for example, does a lot of neurology, cardiology, and they have they invest quite a bit in the physician, make sure they're licensed in all the states, and they can sit in a room in their home that's retrofitted, so it has to have like white walls, and they have to wear a suit, and and it's all very official. But they literally sit there and take calls from all over the country, and they're giving consultations to emergency room physicians. And so it is possible that these solutions will pop up that make that available. I just want to address the Skype issue, and these telemedicine technologies that are available today are secure, HIPAA compliant, oftentimes integrated so they can send electronic health records. I mean, they're very, very sophisticated. And the Skype example hurts the telehealth field a little bit because some folks who are against it or don't want it to proliferate will say, well, it's unsafe, it's insecure, so I just want to emphasize that it's very different from Skype what these telemedicine companies are offering, and it can actually, I mean, for HealthSpot is one of our members, and they actually integrate with the primary care medical home, and so all the records are available to the doctor providing care on the spot and the regular primary care physician, and it's all HIPAA compliant and everything else. So I just want to mention that because we've had to go back and really educate a lot about this isn't Skype.
But if I'm the patient and it's a consult directly with a physician and I'm in my home, do I download the program? How does that work? I mean, if people aren't buying special equipment for their homes.
So the solutions that are available today are largely sponsored through something, a health plan or an employer. Like actually, Daily Piper has a telemedicine provider, Teledoc, so that I can call or video with a physician. But a lot of times it's sponsored. We're just now seeing the direct-to-consumer come up. Doctors on Demand is one of those. But generally the consumer will log in to the system of the provider. So you're not just calling up your doctor like you would call your parents on FaceTime or something. Okay. You're logging in.
Cool.
Do you get more early adopters to get the ball rolling here, so that you have sort of, something for people to miss? The East Berliners peering over the wall to see what they're missing out on in West. I mean, so how do you get more groups like Ray going? Do the ACOs even know about this opportunity? Are they interested? Can we incentivize, get them excited about it, or can you get some VA centers to be the early adopters and become a model that everybody will then sort of catch on to?
The VA is by far a huge leader, and there's just going to be a new report. Actually, we're all anxiously awaiting it. It's within the next 3 weeks. VA is going to release an updated report of their 2008 report about telehealth in the VA. The challenge is that every time you use VA evidence, people say, oh, well, the VA is different. That's a closed system. It's kind of like using Kaiser evidence. People say, oh, well, that doesn't work in the in the rest of the world. So it's a little bit of a challenge for VA and Kaiser. I think the more people know about it, the more, as a working mom, I didn't even know that we had Teledoc at DLA Piper until I started working on this project. And Teledoc came on board with the Alliance and they said, hey, did you know that we were one of our clients? I was like, no. So I went and found my Teledoc card, and I actually used it once, and it was great. Because as a working mom, it's really hard to take off work and take your kids, and if they have pink eye or whatever, it's so much easier. So I think you're going to have the more consumers that use it, the more evangelists that you have. But people just need to know that it's even an option. And given the reimbursement situation, it's not an option for a lot of people in Medicare. And the commercial market's just picking up. And I think one other aspect that will incentivize people is now there's going to be more cost pressure on patients, because we're shifting risk and cost sharing to patients more. So they're going to be looking for lower cost ways to communicate with their physicians. And so you may see some adoption because of that.
Yes.
I'm a Parkinsonian. My daughter is a physician at Kaiser in Oakland. My son lives in Flagstaff, Arizona, and has bipolar illness. What are its uses for mental health?
Oh, it's a huge use case. Do you want to take this one, Ray?
So it's probably the most common, telemedicine is probably the most common applications in psychiatry among the clinical applications that interact directly with patients. It's used widely. There are companies who do nothing but this for people with mental health. I don't have the numbers, but I wouldn't be surprised if there are hundreds of thousands, if not a million Americans who have received mental health services via telemedicine in the United States. And told you in Canada, it's done every day, and people who live outside more than 50 miles away from the U.S. border, people are getting care in satellite clinics. So it's very commonly used for mental health. In prisons where there's lots of mental illness, it's done all the time. You can imagine getting a prisoner out of a prison is difficult, and getting a psychiatrist into a prison is difficult. And those tend to be in rural areas, so it's used all the time. My line with Amy is that, if you're Canadian, if you're a veteran, if you're in the military, if you're a prisoner, you can realize the benefits of telehealth, but if you're a Medicare beneficiary, you generally cannot.
One of the things about behavioral health that's so conducive to telemedicine is people like to be private about it, and they'll drive long distances to receive behavioral health care. So if you can stay in your home and you don't have to, be seen going to a behavioral health specialist, that's one of the reasons why I think telemedicine is such a great use case. I'm not saying that I condone that. I think it's terrible that it's stigmatized, but it's just the way
it's confidentiality that otherwise wouldn't be possible to you for whatever reason, whatever condition it is. I mean, if you go to the Parkinson's disease clinic, you've kind of declared yourself that you have Parkinson's disease, and you may not want to declare that. And that should be your decision, not one that's dictated to you by the healthcare system.
We had a question in the back.
Many of the patients that can be served through telemedicine are immunocompromised. So what are the risks of infection, and have we tried to quantify for the economic argument the risk of infection?
So outstanding point. So it turns out that if you have HIV and you're in a prison in California, you're almost certainly getting your care virtually from an HIV specialist. We have people with ALS, Lou Gehrig's disease, who have impaired respiratory function, and we tell them that the standard of care is that they need to come to a tertiary academic medical center to get exposed to viruses known and unknown. I mean, it just doesn't make sense, and that this is, tremendous applications for providing care to a wide range of individuals. Children with autism, you could readily imagine that a child with autism might prefer to receive his care over a computer than to receive his care in person. If you have Tourette syndrome, I mean, wide variety of conditions. We don't know what the future holds, but we need to adopt and demand policies that enable better models of care to come forward, because we know the current models don't work.
Doug, one more. And then.
Where is the two questions. Where is the private health insurance on this? Because they can be a leader in it, and particularly if they determine that it's more cost effective and better outcome, employers supporting better outcomes. And then the second thing is, how do we get doctors behind it? Because is it just them getting reimbursed by Medicare, or is it them evangelizing more to the benefits of telemedicine or telecare?
Maybe you want to take the doctors and you can take the private payers.
WellPoint has made a huge investment in telemedicine, and they have it as part of their platform, Live Health Online it's called. And so if you're a WellPoint member, you have access to telemedicine anytime, 24 hours a day. I think United does a lot of telemedicine as well. So I think the payers are starting to adopt it, and again, in 20 states it is required that commercial payers reimburse for it. So, but I think WellPoint is really leading the way in saying this is an important tool in the spectrum of tools available to patients, and we're going to invest in it.
So there are two issues for physicians. The first is in malpractice. They're concerned they're going to be more likely to get sued, so having protection for that is a big one. I work for a self-insured institution, so I don't lose too much sleep over that. The second is, there's got to be a financial incentive for them to adopt it. If you think about it, even if the reimbursement were equal, they could just have patients go into what we call a holding cell or a waiting room and wait there all day, and then come and see them at their leisure. In Canada, they have a financial incentive. They actually pay physicians more to provide care via telemedicine. They provide them a technology fee. Medicare currently pays us more to see patients in the hospital-based clinic than in a community-based clinic. If you flip the incentive and incented physicians to provide patient-centered care wherever the patient was, you could see adoption switch like that quickly.
So I want to thank all of you for coming. You can, I'm sure, based on what you've heard tonight, you realize how important this is for all communities, not just the Parkinson's disease community. I see a colleague here tonight who works in the rare disease community. There's great opportunities for helping so many people with various diseases and conditions, and quite frankly, healthy people too, who need telemedicine to fulfill their lives and not spend as much time in the waiting room and wasted time and cost. Tomorrow, Pan will be sending out an email to all of you, thanking you again, of course, for coming, but reminding you what you can do at this stage to move this issue forward. There are pieces of legislation on the Hill. There are things many of your organizations can do to get the message out. And what we really do need here is a movement demanding this, not waiting for it to be offered to us, because that is not working so well. We need a movement asking for change, and I think there's a lot of people in this room who can help that. So thank you again for coming. I hope you will join us for a reception.